Alright, we're just going to do some airway management. So first of all I'm just going to perform a head tilt chin lift just to open the airway. And then going to insert a oropharyngeal airway. So just to measure that, we do that by the corner of the mouth to the angle of the mandible. So this looks like a good size, so I'm just going to insert it 180 degrees to the curve of the mouth, the roof of the mouth, and then insert it in and rotate it 180 degrees just to avoid the tongue and place it in the airway. Just going to assess to see that the patient takes it well, so he's taking it well. So you'd use this on a patient that has a GCS of lower than 8 or verbal response lower than 2. Some complications or contraindications with this is it can induce vomiting if it's too large, can damage the oropharynx, can also worsen the airway if there's an obstruction in there by pushing the tongue posteriorly if it's too small. Okay, now we're just going to insert a nasopharyngeal airway. So first we're going to measure it. So to measure it we do it from the nostril to the earlobe. So this one's pretty small, so we're going to try this one. And that is perfect. So we're just going to apply some lubrication to it just to ease it into the nose. So we're going to do this by placing it 90 degrees to the patient's face and then put it in the right nostril, so it's usually slightly larger. Just push it in, and if you feel any resistance, just twist it until it kind of goes in, until that hits the nostril there. They're good as they don't induce a gag reflex, and also can be good with patients with a high GCS score, or if they have trismus. Contraindications would be if they have a suspect basal skull fracture, or if they have nasal polyps or bleeding. Alright, now we're going to use the suction, so the patient's in the lateral position. So we test the suction by turning it to full force, checking that it goes to above 350 millimeters of mercury when I kick the tube. So it's doing that, so it's got enough power. And then also just going to test it, see that sticking onto my hand. So if it didn't do that, we just check for any leaks or anything in the equipment. So just going to insert it into the patient's mouth as far as the eye can see by placing my finger on the hole, and then just going to rotate in a circular motion around the mouth and out for no longer than 10 seconds. Some contraindications for suction is that it can induce vomiting, also create hypoxia, induce bradycardia, aspirations, could cause soft tissue damage, or cause laryngospasm. We're just going to run some checks on the MRX just to see if it's working all well. We're going to turn it on, and then just going to go to menu. I'm going to go down to other, and then go to operational check, run op check, going to acknowledge that, and wait for a little while. Now I'm going to turn it to 150 because it's requesting. Checking the charge, and then going to administer the shock.
Shock delivered.
Cool, that was successful, so press yes, and then wait for the rest of the checks to be done. Alright, the test was all successful, so it's in good use to use. Now I'm just going to do disarm a shock, so I'm going to do that by just putting it back onto monitor mode. Then I'm going to put it onto 150, charge it up, that's the standard adult dose, and press charge. Wait for it to charge up, and then to disarm I'm going to press this disarm button down here. Now I'm going to, I've attached some leads to my patient here, and I'm just going to change between leads by pressing this button here. So you're on 1, 2, 3, and then that goes to tab. So I'm going to change the volume of the leads. So go to menu, go into volume, go into QRS, and then you can go into different levels. So I'm going to go to loud, and then I'm going to change the amplitude of that. So go into menu, display waves, wave 1, lead 2, and I'm going to change it to times 4. It's reasonably big, and then larger there. And then in here we have the ETCO2 detector. That's this cable here, and this works by just plugging in on the side of the monitor, just in there like that. And that's it. Alright, looks like we have an unconscious patient. I'm going to check to see his responsiveness. Sir, can you hear me? Can you hear me? Right, no response to verbal, no response to pain. I'm just going to check his airway. Head tilt, chin lift. It looks clear. Check for 10 seconds. 1, 2, 10. Alright, we have no breathing. Jess, can you jump on the chest, please?
Yeah.
Okay, we're just going to call comms. AUT1 to comms.
Come in.
Alright, we have an R50 and we need an R49.
Roger.
Going to get the AED ready. Jess, you just carry on with your compressions. I'm just going to work around you. Cool.
Analyzing heart rhythm. Do not touch the patient.
Alright, off the chest, Jess. Stay clear.
Shock advised. Charging. Stay clear of patient.
Alright, everyone stay clear, watch out.
Deliver shock now. Press the shock delivered.
Alright, back on the chest, thanks,
Pause.
Jess.
Start
Alright, I'm going
CPR.
to insert an OPA. Insert bag. Insert that in. Did anyone see what happened to this patient?
No.
No one?
No, I didn't.
Alright, going to turn the oxygen on to 12 to 15 litres per minute. Going to put the good cover over the nose and the mouth and use the C egret as a single user. Just if you could just tell me when you're at 25 and count to 3 or 30. Going to make sure that our airway's open by the head tilt chin lift again. 2 breaths. Right, it appears that the chest is rising, so we're going to do 30 compressions to 2 breaths. The airways sound like it was open and clear, so I'm not going to use suction at this stage, but if that changes, it's there if I need it. So Jess's chest rise, cool. Compression's really good, down 1/3, up 1/3, and there's really good recoil on the chest, so keep that up. After 2 minutes, we're going to swap over when that's reassessing. Ooh, still good chest rise. Cool, keep those compressions up, Jess. Nice and strong. Just waiting for the monitor to reassess.
Stop CPR.
Alright, off the patient, we're going to
Analyzing heart rhythm. Stay clear of patient.
Just watch you're not touching the patient, Jess.
Analyzing heart rhythm. No shock advised.
No shock.
Pause.
Alright, we'll jump back on
If
the
needed,
chest.
start CPR.
I'm going to tell you when I get to 25 and count up to 30. 7, 28, 29, 30. 2 breaths. Good job. 25, 26, 27, 28, 29, 30. Right, it says our patient is not coming to, so we're just, Okay, alright, we're going to do some hemorrhage control. So I've got my glass on and I'm just going to apply my safety goggles just for precaution. Okay, so first of all I'm going to expose the wound, and it all looks like we have a wound here on the forearm. So what we're going to do is, what I could do is use a bandage and just pack it really tightly right into the wound. just to stop that bleed, but today I'm going to use a smaller bandage. The wound is reasonably clear, so or clean, so I'm not going to clean it. So what you could do though is use saline to wash it out. I'm going to use my smallest bandage that I have, place it on there, and then get my bandage and start getting some pressure onto this wound to reduce this bleeding. So we're going to do that by just pulling each time we come round, and then you can also do twisting over the wound so that the twist is over top of where the cut or open wound is. And that just applies really good pressure. You can do it in a figure of 8, just going around to just make sure you cover all areas. I'm going to do that until the bandage is finished. Stopping a little bit, so I'm just going, I have no need for these at the moment. Okay, so we're just going to finish that off with a pin. Right, so it actually appears that the bleeding is continuing, so we have catastrophic bleed happening. So what I'm going to do is I'm going to get a tourniquet. So because it's on the arm, I'm just going to use a single D loop on this. So I'm going to just put that straight on there. And that first D loop there rather than the double D, which is used for your leg. Do it 10 centimetres proximal to the injury. Do it really tight. And then we're going to use this windlass to wind up to really apply that pressure. And we're going to put that, just tuck that in there, seal it up like that. Now to check that it's effective, I'm going to make sure that the distal pulse is not present. Can't feel it. And this appears to be not leaking blood anymore. So if it was even more catastrophic and it kept bleeding, I'd apply another tourniquet about proximal to this one. I'm going to elevate this just to also help with the bleeding, stopping bleeding. I'm going to put the time and the date onto this tourniquet so we know when it's being put on. This is going to be really sore, so we're going to offer the patient some pain relief, call for backup so they can administer even more stronger pain relief, and get this guy to the hospital as soon as possible. Now we're just going to do the bag valve mask. First we're just going to check that it has any leaks, so no leaks there. I'm going to check the bag. Right, that's filling up good, so no leaks. Going to attach that onto there. I'm going to connect it to the oxygen. So this runs with 98% oxygen at 10 to 15 litres per minute. Turn that on. And just check that the reservoir is filling. Looks like it is. Going to perform a head tilt chin lift on the patient to open the airway. Place this on the patient's face, nose first, and then over the mouth, just ensuring a good grip. I'm going to use a CE grip for a single user, and then going to ventilate this patient once every 6 to 8 seconds, and just going to assess for chest rise and gastric inflation. And if you have a second user, they can apply cricoid pressure just to make this more effective if needed. Right, we're just going to do some oxygen delivery. So first we're just going to check that there's a Bodex seal on the regulator. I'm going to attach it onto the oxygen bottle and tighten it up using a quarter turn to make sure it's on there sturdy. And then we're going to turn the oxygen on and just check that there's oxygen in there, cool, and then check the flow rates and they're going well. So I'm going to attach a acute mask for this patient. So put the tubing onto there, a flow rate of 6 to 8, and it's going to deliver 60% oxygen to the patient. Place it on their face. So it's a nice good seal on there. So once that's done, just take that back off, close the oxygen off, and then just to release any oxygen that is still in there, just going to put it through the filter there. Alright, now we're just going to assess any C-spine tenderness. So the first thing we're going to do is look at the mechanism of injury. Then we're going to apply the nexus rule. So if any of the rules, one or more of the rules apply, then you're going to apply a quality So these rules are posterior midline C-spine tenderness if they're intoxicated, if they have a decreased alert mental status, so they're not aware of time and place, if they have any neurological deficit, or if they have any other painful or distracting injuries, then yes, we're going to apply a collar. So we're going to measure it by just placing fingers from just the bottom of the neck to under the jaw, and then placing that onto our collar just to check that the size is right. This is fitted perfectly for Jess, so we're just going to apply this collar by making sure that we have the patient's head in a sniffing position, put the collar underneath, and then just bring it round over the patient's jaw and attach it securely on the other side so it's nice and tight. This will just restrict all movement, holding the C-spine in a stable position. Right, just going to do some fracture management. So first of all, going to expose the wound, and then as this is going to be quite painful, I'm going to offer the patient some pain relief, so some Entonox, so I don't suspect any pneumothorax or any bowel obstruction. Kirsty, have you been diving in the last?
No.
Diving in the last?
No, I haven't.
No, okay. And she's a banker mum, so we can give her that, and she can self-administer that. Now I'm just going to check for neurological and cardiovascular integrity. Going to do that by just checking the colour, comparing with the other foot. Colour looks the same, temperature feels the same. Just going to check cat refill. Same as the other foot. Now I'm just going to see if she can know when I'm touching her on her foot. So I'm just going to, where am I touching you?
On the outer sides of my feet.
Cool, okay, sounds good. Now we're going to apply a splint and a distal pulse. And I can feel that, so that's good. Okay, so Ash, if you could just help me put this thing in. So we're just going to support the fracture, and I'm going to put the splint underneath as we go. So just a small lift underneath there like that. Cool. And there. Okay, so we've applied support to above and below the fracture, just to make sure that that's really snug in there and to hold it still. I'm just going to recheck for neurological and cardiovascular integrity again. So check for a cat refill, still the same as the other side, same with temperature, same with colour, can still get that distal pulse. Yep. And where am I touching you on your feet?
My toes.
Your toes, and that looks good. Managed. Right, just going to do some vital signs. So I'm just going to take Jess's pulse. So I'm going to take it at her radial pulse, and if you have radial pulse, it means that you are about 80 systolic. The normal pulse rate is for an adult is between 60 and 100 beats per minute. And you also got to check the regularity of it, whether it's bounding or whether it's weak. If it's regular or irregular, and if it's irregular, that could show some abnormal cardiac function going on. So Jess, can I take your pulse?
Absolutely.
Cool, so I'm just going to do it for 10 seconds.
Go.
So I've just taken it for 10 seconds, and that was 12 beats, so I'm going to times that by 6, so that's 72 beats per minute, so that's within normal range. And it also feels regular and quite strong as well, which is a good sign. I'm just going to take Jess's blood pressure. Do you mind, Jess?
Not at all.
Okay, so first I'm just going to find the brachial pulse. She's got a really strong one, so that's good. Now I'm going to apply the cuff on the arm, just lining it up with the right artery. Okay, I'm just going to find the brachial pulse again and then pump it up until I can't feel it anymore. It's gone, and I'm just going to place the stethoscope where that is. And then as I release the cuff, I'm just going to, at the first heart sound I can hear is going to be just a systolic pressure, and then when I can't hear it anymore, the last reading I get is the diastolic. Release that. then all to the end to get the air out. So Jess was 115/80, so that's within normal range, and sounds good. Now I'm just going to take Jess's rest rate. So you usually do this visually just by looking at the chest or the stomach and looking for rises. So I'm just going to do that for 15 seconds, if you don't mind, Jess.
Not at all.
Cool. Cool. So Jess's rest rate was 4 breaths in that 15 seconds, so I'm going to times that by 4, and then we get 16 breaths per minute, so that's between the normal range of 12 to 20 breaths per minute. Now I'm just going to auscultate Jess's chest in a mid-axillary, so I'm just going to place that there under the arm, and then if you could just give me some deep breaths, Jess, and I'll just listen to that. Cool, so normal chest sounds will be quiet, noise of rushing air. Abnormal will be wheezes, wet sounds or stridor as such, but or no sounds at all. I'm just going to check the other side to compare. So big deep breaths. Cool, so that sounds really clear and good.